Welcome to your discussion on kidney transplantation at the Halifax Health Center for Transplant Services, which is in close affiliation with the University of Florida. My name is Dr. Ken Andrioni, and myself and my partners, Dr. Mark Johnson and Dr. Narim Batula, are full-time surgeons on faculty at the University of Florida, and we perform all the kidney transplants here at Halifax Health. I welcome you to your discussion here today on kidney transplantation. The explanations in this presentation are created for the average person without a medical background. You have been referred to discuss the possibility of receiving a kidney transplant at the Halifax Health Center for Transplant Services. Your own kidneys have either already failed and you are on dialysis, or your kidney function is far below normal and it is expected that you will require kidney replacement in the near future. Although everyone comes hoping for a new kidney, all the kidneys available for transplant are kindly donated by other people and are hopefully gently used. These kidneys come from either living donors or deceased donors. If anyone you know wants more information about potentially giving you a kidney, all they need to do is call us for more information. People who are in good health without diabetes or severe high blood pressure may be further evaluated for possibly donating a kidney. Deceased donors are people who donate a kidney after they die. They and/or their families have consented to give a kidney and possibly other organs to people like you waiting for transplants. The organ procurement organizations are the people who coordinate the donation process by testing the donors for possible infections and sending the organs to the patients the National Computer Allocation System finds for that particular organ. The quality of the donated kidney is estimated by looking at 10 different characteristics of the donor, such as their age, whether they had diabetes or high blood pressure, and their blood creatinine before donation. This information is used to calculate the Kidney Donor Profile Index, abbreviated to KDPI. Lower numbers, such as 10 or 20, suggest the kidney may last longer after transplant than a kidney with a higher number, such as 50 or 60. This is only an estimate and does not take into account any problems that may occur during the actual transplant surgery or any issues with rejection or recurrence of your kidney disease in the transplant kidney after surgery. How long a kidney may last after transplant declines very gradually until very high numbers of the KDPI are reached, such as 80 or higher. Therefore, the federal government considers a standard kidney transplant to be up to the KDPI number of 85. If you want to be considered for one of these kidneys over KDPI 85, you will need to sign a separate consent form that acknowledges we told you these kidneys may not last as long as those with lower KDPI numbers. But remember, even kidneys with a very high KDPI value of 95 has greater than a 50% chance of lasting more than 5 years after your transplant. The estimated post-transplant survival score is used to determine the patients on the waiting list who would live the longest after kidney transplant and therefore need a kidney that may last a very long time, that is, have a lower KDPI value. Currently, the EPTS is only used to give the 20% of patients with the expected longest survival after transplant preferred access to the 20% of kidneys with the longest potential function or that have a KDPI 1 to 20. Our medical review board will consider whether we feel it is safe to offer you a kidney transplant with the required surgery after review of all your medical tests, your ability to follow through with medical instructions and take your medications every day, and your ability to get to follow-up appointments as needed. If you are considered safe for transplantation, your name will be placed on the national waiting list for a deceased donor kidney. If you have a living donor, we will then evaluate the donor and hopefully move forward with your living donor transplant in the near future if all is well with you and your living donor. Adults can become active on the waiting list if you are currently on dialysis or if your current renal function is 20% of normal or less. You go up and down the list based primarily on three conditions that give you points. You will get 1 point for each year of waiting. This will go back to the day you started outpatient dialysis or when you are activated by the transplant center with your function 20% or less. You gain a fraction of a point every day. The second way you generally gain points is by some degree of matching with a specific donor. You may not tissue match this particular deceased donor and get 0 extra points, or you may match one particular gene and get 1 additional point, or match 2 genes and get 2 additional points. It is fairly common for at least some people who are waiting to match each deceased donor and get at least 1 extra point. This is the reason patients go up and down the list with each donor and why when you may be called for a donated kidney is not always predictable. The third way you may get extra points is if you have antibodies against other people's tissue antigens. If you have a high number of these antibodies, it may be difficult for you to find a donor who is acceptable for you. If you have a very high antibody level against other people, you are at a higher risk of having a rejection episode after transplant, even if the cross-match test for antibodies at the time of the transplant is accepted. An increasing number of deceased donors today fall in the category of increased public health service risk for infectious disease transmission, or PHS increased risk. Here are the types of donors who fall into this category. The first point to consider is that none of us know what anyone else does at home, so there is some risk from receiving an organ from any other person. Even living-related donors have given infections to transplant recipients on rare occasions. The facts that are important for you to clearly understand is that the tests that are done by the organ procurement organizations under federal rule are very good. The major infections we are concerned about are hepatitis B, hepatitis C, and HIV or AIDS. The tests that are done today are extremely accurate to detect one of these virus infections if the incident we are concerned about is more than 1 to 3 weeks ago. For example, if a donor has a homemade non-professional tattoo 22 days ago and the tests done today are normal, there is extremely little chance that they have one of these infections. If they did, the test would turn positive. In fact, the tests for HIV, AIDS, and hepatitis C are accurate to within about a week. So if a donor tests negative for all 3 viruses, the risk that they still may be positive for a virus is very, very small. Here's a government report that tries to explain the risk from these donors. This chart is the best estimates we have of a donor who has the risk factors listed and a negative test, being infected within the last week, so therefore potentially having the virus. The highest risk group is active intravenous drug users. This group's chance of having an HIV or AIDS infection with a negative test is calculated to be less than 0.1% or less than 1 in 1,000. Their chance of having hepatitis C is slightly higher at 0.32 or 3.2 out of 1,000. What is also important for you to understand is that the average person who does hemodialysis in a dialysis center has a greater historic chance of getting hepatitis C at 0.34% or 3.4 out of 1,000 in just 1 year at dialysis. Riding in a car is a real risk we all take nearly every day of our lives. In the US, if you are in a car accident, 1 out of 114 people in a real car accident will die. If you accept a PHS increased risk donor, less than 1 of 300 people will even get any infection. Also, you need to remember that hepatitis C is curable today in over 97% of infected patients with a few weeks of pills. Hepatitis B is almost always easily controlled with 1 pill a day. Even HIV/AIDS is now considered a chronic disease as people live several decades with the appropriate medications. In fact, we even give kidney transplants to well-controlled patients on dialysis with HIV infections at some transplant centers. This group of PHS increased risk donors is generally a younger adult group, so these kidneys have potentially many years of function for the person who receives them. The next 3 slides are from a presentation given by the UNOS Disease Transmission Advisory Committee at the National Transplant Meeting in 2017. This is actual information from transplants done in the United States. You can see the rapid increase in donors who have intravenous drug use, up to 1,222 in 2016, which was 12.3% of all the deceased donors. If you include donors with any other drug intoxication, this is now 17.6% of all donors in 2016. This slide shows that adding up all the donors from 2008 to 2016 reveals that the greatest risk is getting hepatitis C from one of these donors, and it is only 0.12% or 1.2 out of 1,000 donors. Again, hepatitis C is now curable in over 97% of the patients who get it. There were no cases of a donor testing negative for HIV/AIDS with the more sensitive NAT test who then gave HIV/AIDS to a recipient. When you are called for a possible kidney transplant, the coordinator on the phone will tell you some specific details, such as if you are the first person up for a kidney or if you're a backup, if you need to come to the hospital now or just be ready at home, whether you should go to your next dialysis or not. And if the donor has increased PHS risk, you will agree to accept that on the phone or you will not come in for that donor organ. Please remember to tell the coordinator of any recent changes in your health, especially any active infections, recent hospitalizations, or any recent heart issues. If you are admitted to the hospital, we will check for any major infections. We will also obtain your signature on the operative consent form. What you will be signing acknowledges that you have heard and understand the details of what you are learning from this presentation and from all of your written materials and interactions with all of the transplant team members. If the donor is PHS increased risk, you would have already been told this on the phone before coming to the hospital, and you would have already verbally agreed to accept the organ. You then need to sign the form stating that you accept this increased PHS, increased risk donor organ. If the cross-match test between the antibodies in your blood and cells from that donor is good, you will be further prepared for surgery. There is a small chance that the kidney may not be acceptable for transplant due to injury during the removal surgery from the donor or abnormalities found on biopsy of that kidney. Kidney transplantation starts with a major operation. You are put to sleep with medications in your IV, and then a breathing tube is inserted. A central line will be placed in your neck when you are asleep for infusing strong anti-rejection medication. An incision is made on your right or left lower abdomen from an area about 2 inches in front of your hip bone down toward the middle of your abdomen where your bladder is located. The surgeons can usually stay outside of the sac that contains your bowels or intestines, which is called the peritoneal membrane. This allows for less chance to injure the bowel and allows for the bowels to wake up and function more quickly after surgery. The major part of the operation is to dissect your blood vessels in your hip area that are going to and from your leg and give you a small amount of heparin blood thinner if you're not allergic, clamp the blood vessels, make an opening into both the artery and the vein, and connect the kidney graft artery and vein to your blood vessels. The clamps are then removed and the blood is allowed to flow both down your leg and into the kidney graft. After any bleeding is controlled, the ureter tube from the kidney is attached directly to your bladder. A small plastic stent is placed inside the ureter to allow it to scar into place in a gentle curve. This stent will be removed about 4 to 6 weeks after surgery by a scope placed into your bladder. For about half of the patients, we leave a small plastic drain tube to remove any blood for a few days. Most patients will have the breathing tube removed in the operating room as you wake up and brought to the standard recovery room. We will obtain an ultrasound of the kidney to ensure the blood flow in and out of the kidney is good. If there are any concerns for this blood flow, we may go back to the operating room right away to make sure there is nothing to fix. Usually you're in the recovery room a couple of hours and then brought to the intensive care unit for a day or two and then to a regular bed on the ward. Most patients will have their living donor kidney start to work right away after surgery, and most patients receiving a living donor kidney transplant will go home in less than 5 days. Patients who receive a deceased donor kidney will have a wider range of times when the kidney may start to function. Most of these kidneys will wake up from a deceased donor in about 2 to 4 days after surgery, and most of the patients receiving a deceased donor kidney will go home in a week or less. About 8 of 10 patients who receive a deceased donor kidney will go home without requiring any dialysis. 2 of the 10 patients may require dialysis for a few weeks after leaving the hospital, and for these patients, most of them will have the kidney wake up and start to function. Nationally, about 6 to 7 out of 100 patients who have a deceased donor kidney may have the kidney not work well enough to come off dialysis. If this happens to you, you may be able to be placed back on the waiting list and get your original waiting time back so you do not lose your place in line. Most patients do well overall after a kidney transplant, but there are several complications or bumps in the road that can happen early after surgery. Clotting or blockage of the artery or vein in your leg and or in the kidney can occur in about 2 out of 100 patients. This could result in loss of the kidney and or injury to your leg. This occurs more often in patients who have many years of diabetes with hardening of the arteries, or when a kidney has more than one artery, which occurs in about 1 out of 3 kidneys. Bleeding can occur around the kidney, or urine can leak from the bladder and may require a return to the operating room. Wound infections or a hernia may occur in a few patients. These most often occur when patients are obese and with diabetes. After any operation, patients can develop a blood clot in the vein, and in some patients, this blood clot can travel to their lungs and rarely cause death. We use leg compression devices and get you out of bed as soon as possible the day after surgery to decrease this risk of blood clots. If you come in with a low blood count, or if there is more bleeding than usual during the surgery, you may require a blood transfusion. There are nerves that run next to the blood vessels we are operating on, so in some patients, one of these nerves may be injured. Most of the time, this is temporary and resolves with time. As in any major operation, there is a small risk of stroke, heart attack, or even death. These are usually relative to your overall health before surgery. The large majority of kidney transplants work successfully, but about 4 to 6 out of 100 deceased donor grafts and about 2 out of 100 living donor grafts may not work. This is from a combination of blood vessel complications or problems with your heart or lung function after surgery, or low blood pressure, or recurrence of some autoimmune diseases early after transplant, or even early rejection. With all the surgical risk and risk of immunosuppressive medications, as well as the donor graft risk of infection or cancer, most patients who receive a kidney transplant live twice as long as they would have if they stayed on dialysis. Long term, there is a slightly higher risk for some cancers, especially skin cancers and lymphomas. Kidney transplants may last a decade or much more if you take your medications properly and control any diabetes or high blood pressure you may have. Some patients who have autoimmune diseases may have them recur and harm the transplant graft. Is it worth going through all this for a kidney transplant? More than 93 of 100 patients have a functioning kidney transplant 1 year after their surgery. Most patients who have had one kidney transplant want a second one, with many patients having 3 or more transplants over their lifetime if they have kidney disease at a young age. A kidney transplant is the closest replacement we have for your own kidneys. If anything is unclear about this presentation or why you need a transplant, please ask one of us at the Halifax Center for Transplant Services affiliated with the University of Florida. Thank you for your attention. You are very important to us, and this is important education for you and your family. Again, thank you for your attention.